experience dizziness and vertigo and you would truly like to understand the cause of your symptoms. You want to be able to understand your diagnosis better, understand your treatment options. Today, we will be discussing the 5 most common causes of vertigo and dizziness, how to tell the difference between different conditions, and what treatment options that you have. So if you suffer from vertigo, make sure to stay tuned because this video is full of great information. So for those of you who don't know me, my name is Amy McMillin. I am a mobile vestibular therapist in Northeast Ohio, and I have this channel to help other people at home who may not be able to have access to a vestibular therapist to have tips and tricks to treat their dizziness at home. If you haven't already, make sure you subscribe, hit the like button, and share so we can keep growing this content and channel together. So let's start off with the most common cause of vertigo, which is BPPV, benign paroxysmal positional vertigo. For those of you who may be new to that disorder, it's the ear rocks or crystals that you may have heard about that sit in your canals in your inner ear when they should actually be in a different place. And benign paroxysmal positional vertigo presents as a short duration of true spinning, about 30 seconds long, based on position change. After that, the dizziness or spinning subsides, but you might feel off or nauseous with the rest of the day. The main thing is that it's short duration, it is not constant, and it is based on changing position. Now, BPPV is idiopathic, or meaning no known cause in 50 to 70% of cases. BPPV can also be secondary, or meaning related to some event. That event commonly would be vestibular neuronitis, head trauma, viral infections, or post-inner ear surgeries. It's also good to know that people who have been diagnosed with vestibular migraines or Meniere's disease also have an increased risk of developing BPPV. How do we diagnose BPPV? Well, you would do a test, a positional test, the ones that people may or may not be familiar with to trigger those crystals are the bow and lean test, the Dix-Hallpike, or the side-lying test. A trained healthcare provider, a vestibular therapist, ENT or audiologist, or physician may be able to do those tests for you. So if you would like to know how to diagnose or identify BPPV yourself, I can include that in the comments below. It is also in the description of this video as a free download to help you identify if your vertigo is from BPPV. Now, what treatment options do you have? BPPV does not respond to medication. So if you do get McMillin from your provider, it doesn't cure BPPV. It might mask your symptoms a bit, but it's not going to do anything. You may benefit from an anti-nausea medication like Phenergan or Zofran to allow you to do the maneuvers that will actually treat BPPV. What treatment options do we have? First, you do have to identify which canal and which ear you have the crystals out of place. You can go to a healthcare provider to help you distinguish which ear is involved, but the treatment options are going to be canalith repositioning maneuvers. The gold standards are the Epley, the Samant Plus, or if you have it on the horizontal canal, the Gaffoni or the barbecue roll. The least effective treatment for BPPV would be Brandt-Daroff exercises, where you're just asked to lay to one side, get up, and lay to the other side. That doesn't exactly treat the crystals in an effective manner. The studies have shown that eventually it can work to dissolve those crystals, but it's pretty arduous, it takes a long time, and it really provokes a lot of symptoms of vertigo because it's not truly taking the crystals and putting them back in the vestibule where they belong. So my least prescribed would be Brandt-Daroff exercises. Now, the second most common cause of vertigo is vestibular neuronitis or labyrinthitis. Vestibular neuronitis is thought to be an inflammation of the 8th cranial nerve coming off the brainstem. If it involves hearing loss, it is called labyrinthitis. If it only involves the vestibular section of the 8th cranial nerve, it is called neuronitis. So one condition spares your hearing, the other does not. It just causes vertigo. Classically, the presentation is a spontaneous, out of the blue onset. It is constant. It lasts for 24 to 72 hours, and it's constant vertigo, nausea, and a gait imbalance. Oftentimes, you are in bed or going to the ER with this condition. Recent studies show that the most common cause of vestibular neuronitis is related to the herpes simplex virus. They think that that virus actually goes and attacks the nerve, causing the inflammation. Along those same lines, the herpes zoster or shingles virus is also thought to be a culprit of vestibular neuronitis. Other viruses that could lead to neuronitis: measles, mumps, hepatitis, and some influenza viruses. How is it diagnosed? Basically through a bedside exam. Your local vestibular therapist or the ER can identify if you are having a vestibular neuronitis attack. What are our treatment options for vestibular neuronitis? The treatment window with this particular medication is variable in the research. A steroid taper or prednisone pack is effective in the research at reducing that inflammation. McMillin can be beneficial for the first 2 to 3 days in an acute vestibular neuritis attack, but after that, you should be weaning from McMillin because it is a vestibular suppressant and will actually slow your recovery from a vestibular neuronitis attack. And then most importantly, this condition responds very, very well to vestibular rehab. Of course, you should progress at your pace, whatever you're comfortable with, but gaze stability exercises are the gold standard for treating vestibular hypofunction or vestibular neuronitis. So starting those gaze stability exercises in a safe manner, either laying down or seated, as much as you can start to get your head moving. And I have plenty of videos on gaze stability exercises for beginners and advanced. Please check out those videos so you can get started on your gaze stability if you were to be diagnosed with vestibular neuritis. The most important thing I can tell you is if you are trying to do vestibular therapy for vestibular neuronitis, do not do exercises where your eyes move in isolation. This is not effective for neuronitis. So, for example, if you have a video or if you see any of my videos where you're just moving your eyes in isolation, that does nothing for the inner ear nerve and would not be the gold standard for treating hypofunction from a neuronitis. Now, the third most common cause of vertigo is vestibular migraines. Vestibular migraines present as spontaneous, kind of out of the blue, again, anywhere from 5 minutes to 72 hours of constant dizziness, definitely associated with vertigo, nausea. Ringing in the ears is very common. Light sensitivity, sound sensitivity, or smell sensitivity. One of those in the duration of having a vertigo attack. You do not have to have a headache. Studies estimate that anywhere from 25 to 50% of people actually don't have headaches associated with their vestibular migraines. They are diagnosed after having at least 5 spells, normally a history of migraines, and you may or may not have an aura. For those that have like a zigzag or a visual hallucination accompanying their dizziness, it's a lot easier to diagnose, but in my experience, a lot of people don't have auras with their vestibular migraines. Now, it is important to note that there is no hearing loss, but there could be tinnitus. It's more of a high-pitched ring that definitely is associated with your spell. Now, some of the common triggers are weather changes, stress, dehydration, hormonal fluctuations, or dietary triggers. Now, that's a lot of things to be on the lookout for, and that's what makes vestibular migraines so hard to treat, identify, and tackle. Vestibular migraines are unfortunately ruled in by ruling everything else out, which again makes it a very arduous diagnosis to have. You tend to see multiple providers, ENTs, neurology, primary care physicians, neuro-ophthalmologists or ophthalmologists, physical therapists, going through all the tests just to see if you can rule everything else out so then you can rule in vestibular migraines. And the average length of diagnosis in the research currently is 8 years, which I can't imagine having no answers for 8 years. But as we talk about it more and as doctors recognize vestibular migraines, I think we're gonna see that the time it takes to get diagnosed is a lot shorter. Now, the most important thing, how do we treat vestibular migraines? Definitely doing a dietary trigger list and kind of teasing out with a journal what triggers could be involved. Managing stress, getting more regular sleep, staying hydrated. You'll see in one of my other videos, I did mention that in the neighborhood of 15 plus or minus cups of water a day actually leads to decreased frequency of some vestibular conditions, including vestibular migraines, so up your hydration. Getting regular cardio exercise to promote blood flow up to the brain, which is beneficial for those neurotransmitters, which makes everything function in the brain, including serotonin and dopamine. So make sure you're getting your cardio exercise in about 150 minutes a week. Vestibular rehab can be quite effective in managing vestibular migraines, including soft tissue work to the neck stretches, because the neck can be a trigger to migraines, adding vestibular exercises, which include habituation to desensitize to different visual and vestibular motion triggers. We just have to make sure, as proper vestibular therapists, that we dose and prescribe your exercises appropriately, because we don't want to cause migraines or symptoms, which it can happen. So make sure you do work with a vestibular therapist who has a very good understanding of dealing and dosing vestibular exercises with migraines. And the last piece of the puzzle with vestibular migraines is proper medication. So you want to have a good neurologist or primary care physician. There are supplements that can be quite effective with vestibular migraines, including vitamin D, coenzyme Q10, magnesium, melatonin for sleep, and B2 or riboflavin. So medications that can be helpful for vestibular migraines, which you would talk with your physician about, are tricyclic antidepressants, calcium channel blockers, beta blockers, SNRIs, or there are a few other options out there. It's just completely dependent on your presentation and your body chemistry. And that's why it's appropriate to talk with your physician regarding medical management. Now, the fourth most common cause of vertigo is Meniere's disease. Meniere's disease can be quite violent. It tends to present in clusters or spells. The spells last anywhere from 20 minutes to 12 hours, and you'll be symptom-free in between these spells. So after you have an attack, you might feel a little hungover the following day, but then after that, you're fine until the next one hits, which makes it very unsettling to have it out of the blue. But there are some warning signs. So the warning signs preceding an attack tend to be unilateral or one-sided hearing loss preceding an attack, tinnitus, which is more of a roar as opposed to the migraine, which is a high-pitched ringing. So it's more of a roar. Also, ear fullness. And again, it tends to be one-sided. Eventually, you could develop it in the second ear, but that would be pretty rare. And after that attack, the hearing symptoms go away. So your hearing returns, the fullness in the ear goes back to normal, and the ringing will stop. Now, eventually, over time, if you don't manage the condition, you'll have more spells and the hearing loss, and that will degrade over time, and the hearing won't come back. So that's why it's appropriate to try to identify and get the proper management before you get to that point. How is it diagnosed? Diagnosed with an audiology exam where they're looking for low frequency hearing loss. A VEMP test or even an ECOG test will be how you diagnose Meniere's. It's interesting because your hearing test can actually go back to normal if you're not tested during an attack. I don't know who can get to a doctor during an attack, but if you go to the audiologist during, they might be able to find it. If you go after, you might actually have normal tests, which again, the diagnosis can escape you in that way. So during an attack, I suggest to my clients, videotape your eyes. Have your significant other or a child, spouse, try to record your eyes so during an attack we can see. Make note of any hearing loss, ringing, or fullness so we can hopefully identify that this is Meniere's. Now, how is it treated? Through diuretics, if it's appropriate with your physician, or a water pill to help decrease the amount of fluid that's built up in the ear. Steroids to take down the swelling or inflammation in the ear can be appropriate. Other options can include injections directly into the ear, which would be done by your ENT or physician. Other options holistically that you can try are a low sodium diet, low sugar diet, and low caffeine diet. Basically, if you follow what's called a high drops diet, you want to keep your fluids stable throughout the day. You don't want to have a big influx of fluid and then drop down. You want to have just a slow, steady, hydrated state. Now, Salt, sugar, and caffeine can make those fluid changes throughout the day, which can lead to you having Meniere's attacks. Now, is vestibular therapy helpful for Meniere's disease? This might be controversial, but no. Vestibular therapy cannot prevent Meniere's disease attacks. What I can help patients with is education, understanding your disease, making sure that I'm an advocate for you and you know how to talk to your healthcare provider. I do also recommend doing vestibular therapy exercises after an attack occurs. So we can almost reset that vestibular system. So the gaze stability, again, with your head like this, until you feel like you are back to normal, can be effective. So again, check out the videos on gaze stability that I have on my channel. If you have a Meniere's disease attack and you need to reset your vestibular system, that can get you back to feeling better a lot quicker. Now, rounding out the top 5 most common cause of dizziness or vertigo is 3PD, or persistent postural perceptual dizziness. It is the most common cause of chronic dizziness. 3PD includes symptoms of unsteadiness or non-spinning dizziness. It is typically triggered by a true vestibular insult. So after that initial vertiginous attack or spell, it could be BPPV, it could be head trauma, it could be inner ear surgery, it could be neuronitis. So some true vertiginous attack happens and then the 3PD settles after the actual physiologic rehabilitation has occurred and the body is healed, but this 3PD persists after that physiological healing. Now, 3PD symptoms are typically worse when you are up and moving, and absent or almost gone when you are sitting or lying down. It could be provoked by either you moving or your environment moving around you. So if you've heard of visual vertigo is what I call it. So think big box stores like Costco or Target, or if you have people moving around you, or me moving my hands bothers you, that would be more visual environment making you feel dizzy. And that's an indicator of 3PD. Even intense tasks like reading or scrolling on the computer or action television, those visually complex scenarios can also trigger your symptoms. Now, how do we diagnose 3PD? Again, just like migraines, it is ruled in when everything is ruled out. So BPPV is clear, the neuronitis is clear and healed, no active migraine spells, but you still have this persistent kind of vague sense of dizziness. So when the lab tests rule everything else out, we rule 3PD in. Now, how do we treat 3PD? There is great news. There is no need to suffer from chronic dizziness. It can be managed, it can be decreased, you can increase your function. I've been treating 3PD for 15 years without having the research quite to back it up, and the research that's coming out is so exciting because I've been on the right track for all these years. Now, this is a disorder that takes an understanding of the layers of chronic dizziness. So it is not a one-size-fits-all. It's a quite individualized treatment protocol for 3PD. But the general gist of the treatment protocol is habituation, reducing the autonomic nervous system, that fight or flight response, cognitive behavioral therapy, which I incorporate into my vestibular therapy protocol, and then commonly antidepressants or SSRIs or SNRIs, which would be a discussion with your healthcare provider. But that's kind of the trifecta when dealing with 3PD is vestibular therapy with a trained professional, cognitive behavioral therapy with a counselor, and your vestibular therapy should include methods of cognitive behavioral therapy, and then SSRIs or antidepressants with your healthcare provider. Hopefully you can now better understand the different presentation of vertigo and their causes, and can appreciate that some people have multiple diagnoses contributing to their symptoms. But each diagnosis has their own treatment protocols, which in full leads to better results. So if you can figure out what symptoms are linked with which diagnoses, you can take this information to your local vestibular therapist and get appropriate treatment based on your needs. Remember, I am always available to help for vestibular coaching if you would like me to review your case, make sure that you are on the right track, or if any other recommendations or referrals might be warranted. And the vestibular coaching program is great for those who want to tune up, and a vestibular wellness coaching program that they can do in the comfort of their own home. You can find my scheduling link in the bio above. As always, please remember to like, share, and subscribe so I know that you want me to make more content like this and that we can grow this channel together. Until I see you next week, stay healthy, stay strong, and stay steady.